cannula is number 1. Excellent. All right. Next up, what we're going to need is your simple. Oh shoot, do we not have one? Let me go grab one real quick.
Oh.
Your simple face mask. Okay. So what that looks like is it literally looks like your aerosol face mask that has oxygen tubing attached to it. What name did your kit give it?
Is that what it is?
Yes, that is correct.
That's what it
Concentration.
says. Yeah, that's literally what it is.
Concentration, medium concentration, elongated oxygen mask.
Yeah.
Oh my word. Okay, but what it looks like is looks like an aerosol face mask. Yep, that's it. That's correct.
Mine doesn't have a tubing attached to it.
Well, you gotta keep looking.
That's
That's just an aerosol face mask, but we actually have this in there as well. So it looks like an aerosol face mask, but it has the tubing attached to it. But you'll need that too. You might as well keep that out. Good. One. And if you need to put your bag on the table and stand up, me being vertically challenged, I prefer that. So it's up to you if you're having difficulties because it is a lot of stuff. That is correct. Good, good, good. Everyone able to find it? Okay. The next one is going to have a reservoir bag. Oh, I did have one out, Jen. I'm just losing my mind. Okay. So you're gonna have a face mask, but do you see the bag, the reservoir bag that's attached to it? This is a non-rebreather mask. Okay. Good. Yeah, so we have the great job. Excellent. Okay. So it's got the reservoir bag attached to it. That's right. Well done. Good. Okay. How are you doing? Good. Okay. Everyone good? Okay. Last but not least, this is probably the easiest one to find. Okay. It has all the colorful pieces. This is a oxygen entrainment mask or a Venturi mask, and it has all the colorful pieces. Okay. All right. Great job. Everyone good? Excellent. Okay. So what we're talking about today is oxygen therapy. So, you know, last week and the week before when we had our checkoff, you had experienced a patient who was hypoxemic, right? Per evidence by, he had an SpO2 of 91%, he was tachycardic, right? He was short of breath. So, here's what we would do to treat that. So last week and the week before, we didn't quite know what the next step would be, but now we're gonna learn about if someone is hypoxemic, how do we treat that, okay? And there's different types of systems. There's low flow and there's high flow systems. And we're gonna learn how to distinguish when is appropriate to use low flow and when is appropriate to use high flow. Does that sound good? Okay. So first we have some goals of O2 therapy. So if I were to say to you during a checkoff, what are the goals of O2 therapy? What will I be looking for? You can say it. Decrease, everyone together, decrease work of breathing, decrease work of heart, and treat hypoxemia. So when I say to you during a skills checkoff, what are the goals of O2 therapy? What I'm looking for is to decrease the work of breathing, decrease the work of the heart, and to treat hypoxemia. Does that make sense? Okay. The first clinical sign of hypoxemia is this. What is this called? Tachycardia. That is the first clinical sign of hypoxemia is tachycardia. So when the heart is beating faster, do you think that the heart is working harder? So that is kind of what that means, is to treat the work of the heart. Because if we can get rid of that oxygen deficit in the blood, then the heart can go back to beating as normal, hopefully. That's the goal. Does that make sense? When someone presents like Mr. Albert did with accessory muscle use, diaphoresis, retractions, does this patient have an increased work of breathing? When they say, I can't catch my breath, right, dyspneic, does that indicate to you they have an increased work of breathing? So when we decide what type of oxygen therapy we're gonna give them, we're trying to treat the work of breathing. Does that make sense? And then of course, hypoxemia can be evidenced by an EBG, which you haven't learned yet. And we're gonna learn, have you talked about mild hypoxemia, moderate, the classifications? Well, next semester when you have me for a short time in the spring, we're gonna learn how to actually interpret arterial blood gases. And you're gonna learn how to get them at the bedside. So you're gonna learn the skill, you're gonna practice them in your clinical setting, and we're gonna learn how to interpret them, okay? So that's what that means by treat hypoxemia. So we have mild hypoxemia, moderate hypoxemia, and then severe hypoxemia, which we would probably intubate for, but we'll learn about that later, okay? Any questions about the goals and what we're trying to accomplish? But of course, oxygen is a drug. So what do we always need before we give this to a patient? We have to have a doctor's order. This is a drug, and this has hazards and complications that we can cause for our patient, okay? So O2 induced hypoventilation, what population of patients may that impact?
COPD.
Like a COPD retainer, right? That works off of their peripheral chemoreceptors. Have we learned about this yet?
Yes.
Central versus peripheral chemoreceptors. So remember, your peripheral chemoreceptors respond to a PaO2 of what? Usually around the 60s. So if we raise that too high and the central chemoreceptors don't work, the patient will actually stop breathing or become very, very bradypneic until their PaO2 drops down to where their peripheral chemoreceptors can pick up again. And then they start breathing like normal. Does that make sense? Okay. O2 toxicity. So oxygen can also mix and become a free radical and cause inflammatory responses in the lungs. Okay, so you can have O2 toxicity. ROP, retinopathy of prematurity. That is when you have neonatal, small pediatric patients that are on higher levels of FiO2. And what happens is they have additional capillaries that form in the eye and actually physically detach the retina from the eye. It can lead to lifelong blindness. Some cases can be surgically repaired. My niece was born at 20 on Halloween. So funny story. I used to go like real hard before I had kids on Halloween. Okay. So I was getting ready to put my wig on. I had like full makeup on, full makeup. I was gonna be, I can't even remember, but I had like, it was a lot. And I get the call around 10 o'clock that Noelle, my sister-in-law, was actively in labor. So Jada was 28 and a half weeks, so of course way too early, but they had kept her out of labor medically, pharmacologically for a week. So that was pretty impressive because a lot can happen developmentally for a fetus in a week. So I go there, I look crazy, but it was okay. And at 12:31, she was born and immediately intubated and taken to the NICU. And a large part of the time, she was in the NICU for 3 months, a large part of that time on the mechanical ventilator on very high FiO2, but every week they would come through and check the retinas. Because if something happened, they wanted to intervene as quickly as possible so the child didn't have blindness. Because micropreemies have a whole host of things that they can experience down the line. So that's one thing that we want to avoid. Does that make sense?
Yes.
Nitrogen washout. So remember, nitrogen is an inert gas that helps to stabilize our alveoli, right? So if we wash that out along with surfactant, surface tension, so if we wash out that nitrogen, what happens? Boop, right? It can easily collapse because it kind of destabilizes the alveoli. Any alveoli that collapse can no longer take part in gas exchange. So is that good or bad? That's really bad, right? Because we need to get rid of CO2 and bring oxygen in. So what that's called, do you know what that's called when you have nitrogen washout and then as a result atelectasis? What kind of atelectasis? Have you heard it? I feel like you're about to say it, John. Absorption. Yes, absorption atelectasis. Excellent. Okay. So lots of things can happen from O2 therapy. So we want to use it safely and appropriately. We're going to talk about high flow in a moment. What we're going to start with is a low flow system. Oh, can everyone see that okay? Do you want me to turn this light off? Is that better? Okay, very good. So there's low flow and high flow systems, and no one is going to tell you which one to use. Essentially, your doctor's order is going to be somewhere in the ballpark, and Professor Quinn, you can back me up with this. It's going to be somewhere in the ballpark of O2 therapy to keep SpO2 greater than 88%, 90%, 92%, 95%, right? Do you ever see it? I mean, the only exception to that usually is a trach collar. When someone has an aerosol trach collar, it will say a specific FiO2 because you have to go and check that more often. But otherwise, it's really up to the discretion of the respiratory therapist. Is that correct? Okay? So that's kind of what you're looking for. Okay, so we have to know as respiratory therapists what is appropriate and what isn't. Sound good? Okay. So, low flow does not meet all the needs of the patient. This will make a little bit more sense in a little, this will make more sense in a little bit. But does not meet all the needs of the patient. The FiO2, and what that means is like the FiO2, which is the fraction of inspired oxygen. Because remember, it's like 28%, 35%, so that's the fraction of inspired oxygen. That can change with a low flow system depending on the patient's tidal volume and respiratory rate. So for example, if I have a nasal cannula in and I'm breathing like this, versus, do you see how the first example could entrain lots more room air? I'm taking these big giant breaths in and out of my nose whistle. This is not a good time of year for me, okay? This is ragweed season. So when you entrain more room air, you lower the fraction of inspired oxygen. So it's all over the place. It's not exact. It's gonna change based on your patient, okay?
So when you inhale deeper, the FiO2 is lower. Because the oxygen is like diluted.
That's a very good way of putting it. Did everyone hear that?
Yes.
Okay. So you're going to have a patient that's more stable. Does that make sense? So you need regular and constant respiratory patterns. So if someone is Kussmaul breathing or Cheyne-Stokes or apnoistic breathing, right? Or tachypneic. They're not going to meet the needs for a low flow system. They also have to have a tidal volume between 5 and 7 cc's per kilogram. That can be very difficult to like measure, but we know what a normal breathing looks like, right? So if someone is very, very shallow breathing, hypopnea, you can see that. That is not going to be a normal tidal volume. Does that make sense? Through chest rise and breath sounds. So if someone's shallow breathing, okay?
No, I don't want to cut you off. I'll wait till you.
No, what's up?
So then how come? So if the FiO2 drops when you breathe deeper, how come you become more acidotic when you breathe? Like, I'll
I think you're going beyond.
Yeah.
Because have you learned about like acidosis and how to classify it?
We talked about it, like the levels in an ABG, but that's about it.
You have a great thought process, but I don't want you to get too far ahead. But it will make sense. It all comes together, I promise. So you want someone, so if we like look at each other, remember we were like doing patient assessment and we all had a normal tidal volume, okay? So that is kind of what we're looking for, a normal pattern and normal chest rise and fall. Make sense? Also, the respiratory rate has to be greater than or equal to, no, I'm sorry, less than, I can't with the Pac-Man. It's like a lifelong journey for me of greater than and less than. Okay, so what I meant to say is less than or equal to 25 breaths per minute. Okay? Does that make sense?
Yeah.
So if at any moment any one of these criteria is not met, they no longer qualify for low flow. Even if it's just the respiratory rate, they no longer qualify.
So it's all or nothing.
It's all or nothing. Yes, Chantel. Does that make sense? Okay. Does anyone communicate with Jackie or anything?
I messaged her. She answers.
Okay, she's okay. All right, very good. The mom starts to come out of me and I'm like, okay, all right. Hey, Professor Quinn, do you have, could we maybe email Jackie to see if she's okay?
Yes, ma'am.
Okay, because it's been quite a bit. I'm just getting a little worried. Okay, thank you. I'm sorry. Sorry, everybody.
I'm just doing some e-value calculations over here for the blender, so I'll try.
Is it working out okay? Got it. Okay. All
I
right.
figured I'd go back and do them all. See
Okay.
what we ended up with.
Awesome sauce. All right. No worries. Okay, so for example, the patient has a normal tidal volume and a normal pattern, but the respiratory rate is 30 breaths per minute. Do they still qualify for a low flow
No.
system? No. So if they have a respiratory rate of 20, a normal tidal volume, but they have Kussmaul respiratory pattern, do they still qualify for low flow system? Does that make sense?
Yeah.
Or if they have a normal respiratory rate, a normal pattern, but they have very shallow breathing, do they still qualify for low flow?
No.
Does that make sense though? So you would immediately go to a high flow system, which we'll talk about in a little bit. Okay? But first you have to determine whether or not they qualify for a high flow or a low flow. So what we're gonna do now is we're gonna go through the low flow system. Okay? We're gonna do it together. So number one, we have a nasal cannula. Okay? Low flow system. It provides anywhere from approximately 24% to approximately 44%. Do you know why I say approximately? Because does the FiO2 stay the same?
No.
No. What does it depend on?
The patient.
The patient's tidal volume and respiratory rate and how much room air they're in training. Does that make sense? But there are some great advantages to this system, right? I'm not putting this in, but you have it. And everybody take a look at your nasal cannula for me. So when you look at it, you can see that there are like a curve in the nasal prongs. It's not a huge curve, it's just a little bit of a curve, okay? And what's really important about that is we want to make sure that this goes on the patient and then around, I'm not gonna put it in my nose, okay? Around, okay. And then you would tighten this up. So do you see how this goes on? So around the ear, under the chin, and are we gonna choke the patient out with this? No, we don't wanna cause any pressure sores behind the ear, but this would go in the little, it has like a little, what would you call this little thing? A flange or something? And that kind of rests right on the lip, but you would make sure those are in the nares, okay? Does that make sense?
Yes.
What's really great about this system is and we're gonna practice this with Hal. I want to tell you something. He has very teeny tiny nares, okay? I have been in a huge argument with this company about them trying to tell me that is a normal size for a nair. And I'm like, sir, I have been a respiratory therapist for a long time and also a human for a long time. And I know that that's not a normal size, This will make a big difference when we get the suctioning. So you do kind of have to manipulate it into his nares. I understand, but they were not in the mood to let me win that battle. Okay, so just remember when you're practicing, you do kind of have to wiggle it in there a bit, but the really big thing is we want to make sure that it curves toward the patient. If we curve it away, it's going to press up against the inside of the nair and can cause pressure damage, and also can impact the flow. Okay, so it has to curve, and if everybody looked at that, toward the patient. Does that make sense? Some great advantages of this system: the patient can still take a drink, talk very easily, eat food. This is all very important stuff. It's important to me, especially food. Has anyone ever heard of like hanger? Yeah, so when a patient's already not feeling well and then they can't eat because they have to have an oxygen mask on, things can get a little tense, okay? So this is great for our patient. What if we had to run it at 4 liters per minute? What would we add?
Humidity. Humidity.
What is it called?
Bubble humidifier.
Bubble humidifier. What's the approximate humidity that this delivers?
30.
Like 25 to 30, right? Didn't you get like a greater than 25 or something? Around 25 to 30%. So 4 liters per minute to 6 liters per minute, we always add a bubble humidifier whether the patient asks for one or not. We can also add it, which if I ever had to have this, I would be like, just bring the humidity, because my nose will bleed all over the place because I have sinus problems and it will be too dry. So remember, 4 to 6 liters per minute, or if they complain of dryness. Okay? So great system. Do you notice a pattern in the FiO2 it delivers?
Yeah.
What does it go up by?
0.4.
So if you understand that we start at 24% approximately, then you can just add 4 for each liter per minute. 24%, about 24% for 1 liter per minute. About 28% for 2 liters per minute. About 32% for 3 liters per minute, right? Does this make sense? Yes.
Professor Forrester showed us a calculation, but of course I didn't write it down. Do you know it?
I don't have it, and I won't ask you that in here, but I would maybe figure it out if you're gonna have to know it for your exam. But that's not something, I will show you. I do have a calculation for total flow, but that's for high flow systems. And what kind of system is a nasal cannula?
Low flow.
Does that, maybe that's what you're thinking about? Are you thinking about the high?
No, it was a mathematical calculation. She said
For the nasal
multiply something by the other, and it'll give it.
It's for high flow,
Yeah,
yeah.
for high
Oh,
flow.
okay, and we will talk about that. For the nasal cannula, I wasn't sure, but yes, for high flow, that's coming, it's coming. Okay? Any questions about the nasal cannula? Sometimes with patients, especially the elderly population or someone who's on chronic corticosteroid therapy, you can have like thinning of the skin. So we can use little foam pieces that can go behind the skin, and they have those at the hospitals. I think about the skin breakdown here. So there's something, I don't know if it's called duoderm. What is it called? It always has a different name.
Yeah, like the skin colored stuff is duoderm.
Yeah, it just protects. It's like almost like a protectant of skin that we can put here if that starts to break down. Great question.
We use a leave-in at Northwest. It's like the pink wounds. Like if you've ever had anybody in the hospital that has a little pink bandage on their tailbone, we use that like over the ears and on the cheeks.
Yeah.
Because it absorbs moisture. It does have adhesive on the edges. It's really easy on the skin. It moves nicely.
It can breathe.
Yeah.
Okay.
So that's just what our wound nurses have decided we use. It varies.
And it does vary from facility to facility, which you'll notice when you get out there. But just some things that we are checking for skin breakdown. Okay, so if you do start to notice skin breakdown, you have to chart that, and we have to use the appropriate intervention so we can protect the skin from further skin breakdown. Wound care is a huge thing in the hospital, so that's why I mentioned that. Does that make sense? Mm-hmm. Okay. Any questions about the nasal cannula? And we're gonna practice all of it, okay? Next up, this has a very long name, but this is your simple face mask, okay? And this is the one with the mask with like the tubing attached to it, just like that, okay? So this is your simple face mask. This is a low flow system, okay? Simple face mask, low flow system. So low flow, does that mean the FiO2 is gonna stay the same, or is it gonna change based on your patient? It's gonna change based on your patient. The minimum liter flow that we run this off of is 5 liters per minute, no less. You can go higher. Typically we can run this from like 5 to 10 liters per minute, but no lower than 5 liters per minute on the oxygen flow meter. The reason for that is we want to make sure that we blow out any CO2 that is building up in the mask. Does that make sense? Mm-hmm. This can run anywhere from approximately 35% to 50%. Approximately 35 to 50% on a good day. It really depends on your patient's tidal volume and respiratory rate. I can tell you that this is not used very often. The only times I've really ever seen it is like a patient who's coming out of recovery, like surgery recovery, and they're like, that's when I've seen it. And the nasal cannula is not necessarily gonna work very well if they're breathing, if they're like, half in and out and they're breathing in and out of their mouth. Does that make sense? Mm-hmm. Once the patient starts to like come back to life and rejoin us, then we can put them on a nasal cannula. That is the only time I've ever seen this.
I've never used that.
Ever. And I didn't put it on. I took it off. Does that make sense? Mm-hmm. But you still have to know it. The most important thing you have to know about this is the minimum liter flow, that it's a low flow system. You have to run it at a minimum of 5. Are you okay?
No, I'll wait
Okay.
till that. I wanted to show you something, but I'll wait.
Okay. A minimum of 5 liters per minute and approximately 35 to 50% on a great day. It depends on your patient. Can I eat and drink with this on?
No.
No. Okay? Yeah.
What might be what you said? Why you don't like these? Why they don't like these?
Oh, it's not like I don't like them per se. I just think that the nasal cannula is a better option for our patient. Can we hook this up to a bubble humidifier?
Yes.
No. Too much oxygen.
What's the only piece of equipment that we can hook up to a bubble humidifier?
Cannula.
The nasal cannula. Will you see other things hooked up to it?
Yeah.
Yes. And you immediately take it off and put it directly on the flow meter. Make sense? Okay. Next, I want you to get out the reservoir bag. It's the mask with the attached reservoir bag. So I'm gonna tell you about something called a partial non-rebreather, but you do not have a partial non-rebreather, and I'm gonna show you all the differences between a non-rebreather and a partial. You have a non-rebreather, but you will see probably on your test partial non-rebreather, and that's why I have to cover it, even though you will not really see this out there at all. Separately, you have to make it. You'll see what I'm saying. So when you look at your non-rebreather mask, do you see the one-way tabs? They're like a eggshell. Is that a good color for it? Do you see the two? Oh, yours are clear. Mine are eggshell. Yours are clear. What's wrong?
That's cool.
What are we looking at?
Good that they're clear.
Oh, okay. So you have the one-way valves. See how my partial non-rebreather does not have any of those valves? Okay? Don't take your valves off. Don't take them off. They're a pain in the butt to get back on. But I wanted you to see how mine doesn't, this is the partial non-rebreather, and it does not have those one-way valves on the mask.
Well, I never noticed that either. Wow.
See how it doesn't have those two,
This is
they're
a
called one-way
partial
valves.
mask.
So it does not have those on the partial. That is the major difference between your non-rebreather and your partial non-rebreather. Do you see how there's no one-way valves? See that okay?
So
Everybody,
That's what differentiates. I never knew.
yeah? So your partial non-rebreather, high flow or low flow, what do you think?
Low.
It is a low flow, good job. So, this is going to deliver approximately 50 to 70%. Okay, it depends on your patient's what?
That's all.
I forgot FiO2 there.
Breathing pattern?
Well, more so their respiratory rate and their tidal volume. It depends on how much room air they're in training. Does that make sense? So partial non-rebreather is about 50 to 70%, approximately, okay? The way that this works, so this is going to be hooked up to a flow meter. What is our friend?
10.
There we go, 10. So I'm gonna turn this on and make sure I talk loud. So you can run this, you started at 10 liters per minute, okay? I'm gonna cover this and let the reservoir bag, see how that fills up? Okay? So before we put that on our patient, we would typically, ideally want that to fill up. I had to block it, I'm gonna have gloves on, right? So I had to block it to allow that to fill. And this is on 10 liters per minute, okay? Everyone good? What we do, so since there is no one-way valve here over the reservoir bag, literally the patient is going to be inhaling and exhaling and partially rebreathing what they exhale. So when they exhale, part of what they exhale goes into the reservoir bag, part of it goes out. So when they breathe in again, they are partially rebreathing what they have exhaled. That's why they call it a partial non-rebreather gas. Does that make sense? Now, how do we know, this is on 10 liters per minute about, how do we know if we have to go up on the flow rate? Have you talked about this in class?
The bag is deflated.
If the bag deflates more than 1/3 when the patient inhales, so they're really sucking it out of the bag, then we increase the flow. So if I'm on 10 liters per minute, I'm noticing the bag deflates when they inhale more than 1/3, I'm gonna turn up my flow to maybe 12 liters per minute. And then I'm gonna watch my patient and see and watch the bag. Does it decrease or deflate more than 1/3? If it does, I'm gonna go up to maybe 15 liters per minute. Does that make sense? And you just keep observing your patient. Sound good for the partial non-rebreather? What kind of system is it?
Low flow.
A low flow system. The holes in the side of the face mask allows the patient to expire and get rid of what? CO2. Excellent. What liter flow at minimum do we run this at?
10.
10 liters per minute. How do we know if we have to increase the flow rate?
When the bag is deflated.
If the bag deflates more than
1%.
1/3, go up on your flow rate. High flow or low flow?
Low flow.
What is the approximate FiO2 we can deliver with this, the range?
50 to 70%.
50 to 70%. It depends on the patient's respiratory rate and tidal volume. Does that make sense? Okay. But remember, all the while, these are all low flow systems, so the patient, how do they qualify for this? They have to have a normal tidal volume, normal respiratory pattern, and a respiratory rate of
Less
Less
than
than 25.
25 or less.
Okay.
Make sense? Okay, so the patient is still qualifying for this, all right? Next up is what you have. So that is your, oh, I'm like, where'd it go? Your non-rebreather mask. Still a low flow system, although in the hospital, this is not used as a low flow system. It's used for a Band-Aid quickly for anything. Right, Professor Quinn? Yeah. Okay, so non-rebreather mask. We typically state that this goes up to 100%, but it's really, the range is gonna be about 80 to 100%. Although we call it 100% non-rebreather mask, do you think this is always gonna give 100%?
No.
No, it can't. It's a low flow system. Although we call it 100% non-rebreather mask, it's technically incorrect because this FiO2 can change based on the patient's respiratory rate and tidal volume. Does that make sense? Okay. Everyone doing okay so far? And we may, right here, we might have a little time before Professor Nolan comes if you want to, because we're doing pretty good here. I'm very pleased. All right. So, what do you think we want to run this at a minimum?
10 to 15 liters.
Same thing, same as the partial non-rebreather, 10 to 15 liters per minute, okay? And we watch the reservoir bag. How do we know if we have to increase the flow rate?
Deflated bag.
If it deflates
One
more
third.
than or by 1/3 during inspiration, you go up on the flow, same as the partial non-rebreather, okay? The major difference between the two masks is this one now has two one-way valves. Yours are clear, mine are eggshell. You'll see them both. I feel like I've seen green on my lifetime. I don't. I'm almost positive.
Green one.
Like the one-way valves, like once upon a time.
Yeah.
Like not often, but I also don't see clear very often.
No, that's
Or
why.
that's
when
like
you
an
said that, I
opaque.
was like, what?
And why is it? It's shaped a little different too.
I've seen
Yeah.
green masks.
It looks.
I have
like
seen
a
green
full
mask,
visual
yeah.
valve, not just a little flat.
So do you see the one-way valves? And you have them too, so we can kind of follow along together. Because I'm going to tell you how this works differently from the partial non-rebreather. So the one-way valves, the way that they work is when the patient inhales. This one-way valve here on the side of the mask closes. It prevents them from entraining a lot of room air. Some still gonna get in through the other side, but it cuts it in half. So the patient, when they inhale, they're entraining less room air. Also, at the same time, when they're inhaling, this one-way valve opens. What is the FiO2 you think of the oxygen in this bag? 100%. No, it actually is in this one.
Oh, really?
It just depends on how much room air they entrain here as to what the actual FiO2 is, okay? So when they inhale, this valve closes, preventing them from bringing a lot of room air in, and this one opens, giving them all fresh 100% oxygen. What's gonna depend on what the actual FiO2 is how much room air they're pulling in through the other side that's open. That's gonna cause the range. Does that make sense? So when they exhale, inhaling makes sense, right? Then when they exhale, this valve covering the reservoir mask closes so that whatever they're exhaling can't go into the reservoir bag like it could before. And then this one-way valve on the side of the mask opens to allow them to flush out CO2. Does that make sense? We'll go over it again. Okay? And it really all has to do with one-way valve. So when somebody inhales while they're wearing this mask, this one-way valve on the side of the mask closes. This one-way valve that covers the reservoir bag opens. So what that does is gives them a fresh influx of oxygen. Okay? When they exhale, this one-way valve covering the reservoir bag closes so that they can't exhale into the reservoir bag. Hence, non-rebreather. Also, the one on the side of the mask opens so that they can get rid of what?
CO2.
CO2. Does that make sense?
Yes.
So this is a up to 100% non-rebreather mask. It is an awesome mask for emergent situations. But let me tell you something. This is gonna drive you nuts now that you notice it. You're welcome. On like a TV show, when they just plop this on someone's face, and this is like completely flat, and you can see it like steaming up, they're like suffocating the poor actor or actress. Okay? This should be full. That like drives me crazy. And they're like, you're gonna be okay. And I'm like, maybe a little dizzy, but okay. All right?
Okay.
This should be inflated before we put it on the patient. All you have to do is take your gloved, clean hand and hold this down, the one-way valve, and this will fill up very quickly.
Okay.
What is the minimum liter flow we run this on, the non-rebreather mask?
10.
10 liters per minute, but you can go up to flush or 15. How do we know if we have to increase the flow rate?
When the bag deflates to 1/3.
If the bag deflates by 1/3 on inspiration, turn up the flow. Okay? This delivers up to 100%. Is it a high flow or low flow system?
Low flow.
It is a low flow system. Does this give an exact unchanging FiO2? No, it's gonna change based on your patient, their respiratory rate, and their tidal volume.
Okay.
Does that make sense? Everyone doing good?
Yes. I
Excellent.
have a question.
Sure.
So mine have the valve is covered.
Yeah,
I
mine
think I
has
always have 2 of those.
Oh, you would have to take one of those off.
Oh,
Okay.
okay.
So theirs has 2. Wait a minute. Does everybody have 2? Because I don't
Yes.
see 2 on yours.
Mine
Yours has 2.
So I have 2.
So you would typically take one off
Okay.
on the side of the mask so we don't cause any CO2 retention or buildup.
Okay.
So you would only want one-way valve on the side of the mask and one covering the reservoir bag.
Okay.
You would take this off because they would need to have more diffusion of CO2. Does that make sense?
Yes.
All right. Just checking something real quick. Okay, we're gonna do that. Okay. The chart here on this one is different from your Hess textbook. I use on page 302 of your Hess. I wanted to just be on the same page as you.
Mhm.
I don't want you to get confused. So you can disregard the chart in the lab PowerPoint because
Okay.
both myself, Professor Quinn, and Professor Forrester are using the one in your Hess because that is the one you have and you have access to. They can range very slightly from textbook to textbook, so I want us all to be on the same page. So when we get to total flow, we're gonna use on page 302. That's what I drew on the board. So you don't have to draw it once I bring the screen up. Page 302.
Mhm.
Yes.
That's what it was. She
Yeah.
said add the 2 concentration numbers up and it'll give you the FiO2. That's what she told me.
Yeah, and we're gonna get to that, I promise. Okay, sound good?
Yes.
So next what we're gonna talk about is high flow systems. Any questions about the low flow systems thus far? Do they make sense? You're gonna have to be responsible for setting it up, for knowing when to choose high flow or low flow, for knowing where to start, knowing when it's not appropriate. So let's think about this. How do we determine if the patient qualified for low flow? What do we have to do?
Check the
Assess.
orders.
Check your order first, yes, and then we also have to
Assess
assess
the patient.
our patient. What are we going to assess?
Breath sound.
Breath sound.
Breath sounds,
Chest rise. and
chest
fall.
rise, if they have any, your inspection, right? Do they have any accessory muscle use?
Ooh, can I say something?
Yeah.
I noticed in checkoffs this past week,
Mhm.
the thing that most people missed asking about was, were they diaphoretic, what their skin tone, like if they have cyanosis or not, and accessory muscle use. Like, I don't know if you noticed those things in your room, but to me, these are the 3 things when we did our checkoffs that we were all missing. Almost everybody at least missed one of those. So remember, inspection is part of it.
Yeah.
You're walking in and you're looking at your patient. Remember, that's part of how you determine if they're in respiratory distress or not. Sorry, I'm glad that came up.
Yeah,
'Cause I just wanted to
and
mention
what's really good to practice that because these HAL mannequins don't sweat, right? They don't have retractions, do they?
No.
Not that I know of.
It'd be really
Or accessory muscle use. So this is also when you're practicing something to help to become habit is to say it out loud. Now, when you get into clinicals, this will start to roll together. But we have to, the reason we can't do it in the first semester is you just have to know something before we can send you out there so it's safe. So that's one thing to help you with that, repetition. How do we learn how to ride a bike?
Okay.
Through
Practice.
practice. I still can't. And repetition, okay? If you don't use it, you
Lose it.
lose it. It's like a muscle. Our brain is a muscle. So like Professor Quinn said, these are very important things. And since we can't really see it on the mannequin, it can sometimes get lost in translation. So practice with each other, practice by yourself, saying it out loud over and over again, okay? So we're going to inspect our patient, accessory muscle use, retractions, diaphoresis, color. Is there any cyanosis? What else are we assessing?
Retraction.
Vital signs, so
Vital signs, which includes
Pulse oxy.
heart rate or pulse rate, respiratory rate,
Blood pressure.
blood pressure, temperature, SpO2. Okay? So these, what do we want to ask our patient maybe to do?
Cough.
Why do we do that?
They can protect their airway.
See how their ability to protect their airway.
Mm-hmm.
As their cough gets weaker and weaker, they have a diminished ability to protect their airway, or a decreased ability to protect their airway. So this is everything we're assessing. And if you checked off with me, what was one of my favorite things to assess?
Subjective question.
Their subjective response. What does that mean? What is someone's subjective response? Y'all forget that quick.
It's how the patient describes how they feel.
It is the patient's perception of how they feel. Do you think the patient is important in this equation?
Yes.
Here, I put this non-rebreather mask on. Do you feel any better? No. Okay. Well, let's reassess and maybe try something different, okay? Does that make sense? Or they're like, I feel so much better. Thank you. Great.
And you're gonna know pretty quick with a non-rebreather.
Yes. So we want to take, I think what happens in healthcare is the patient simply becomes a problem. We forget to look at the patient. We forget that they're a human being.
Right.
We talk over them. We talk at them. We don't talk to them and with them. So the subjective response to me, if they can respond, is very, very at the top of the list. So I will always ask you that. If they can't respond, do you think we still talk to them like we would if they could?
Yes.
Yes, your hearing is your last sense to go before you pass. Yep. Okay? Probably got that from near-death experiences. I'm not sure. Or they look at when someone's dying, they may have put some EEGs on the brain to see what part shuts down last. But it is your hearing. So we
Patients
always talk.
will tell me they recognize my voice when they're extubated and off of station. So like I speak to them when I'm doing things with them
Everything.
at bedside, and they'll be like, "Were you took care of me, didn't you? I recognize your voice." So
Yeah.
they hear you.
So we're always assessing our patient. That is the only way if we're gonna know if they need oxygen, if the O2 therapy is working, or if we need to maybe advance the O2 therapy or the therapies which you'll learn later down the line. It's assessment, assessment, assessment. That's the only way we can tell. Okay? So say we have a patient on a low flow system and we come back to check them, they're on a nasal cannula. Now their respiratory rate is 32. Do they still qualify for that nasal cannula low flow system?
No.
So what do we have to go to?
High flow.
A high flow. A high flow system meets all the patient's needs. It maintains a consistent FiO2, meaning that it will not change based on your patient's changing tidal volume and respiratory rate. So if you put them on a 28% venti mask, it will not change, no matter what. It will always give them a 28%, as an example. Does that make sense? Any high flow system uses the Venturi principle. Has anyone heard this before? There is a bunch of it's very physics based. I barely made it through physics 1 and 2, barely. And I studied constantly, okay? I practically lived in Smith Hall. So it's not my strong suit. So if you like enjoy physics, that's great. There is a much more complicated version of the definition. What I would like to tell you, it is the entrainment of room air with oxygen to give an exact FiO2. I like that definition.
Yep.
It's up to you if you want to use that or not. So it's the entrainment of room air, which, what is the FiO2 of room air?
21%.
21% with oxygen to give you an exact FiO2. All high flow systems use the Venturi principle. Make sense? Okay. So your Venturi mask is a high flow system. Do you think the Venturi mask uses the Venturi principle?
Yes.
Yes.
Hey, hey friend. Hey friend. Hey friend. Does anyone remember this call?
All purpose is it. Number one.
Non-disclosure.
This is non-disposable. Very good. This also uses the Venturi principle. Do you think, in addition to all the other lovely things this device can do, that it can also give us an exact FiO2 if it uses the Venturi principle? Yes. So if you notice when you're practicing today, if you look at your all-purpose jet nab, I can set an exact FiO2. So I say I want 40%. I can set this at 40%. So they're going to get, and can we add heat to this
Yes.
if we need to? When would we add heat?
When we bypass the.
If we have a bypassed upper airway, like if they're on have an ET tube or have a tracheostomy. Okay? So another wonderful thing that this system can do. All-purpose jet neb. Okay? But first we're going to start with the Venturi mask. So if everybody wants to get out your Venturi mask.
This is one you're definitely gonna need a belt for.
Okay. And we have all these pretty pieces. All right. 6 in total. I'm gonna. So there are also systems, and we can show you in a minute, that kind of combine all these pieces together. But the one you're going to be tested on, you know what I'm talking about, the green one, where you can spin it. I think we have one. I don't know where we have one. Yeah. So those are good too, but the one you're going to be tested on is this system. There are 6 pieces in all Venturi setups, and you're going to have to know all 6 FiO2. 24%, 28%, 31%, 35%, 40%, and 50%. You will have to know that without even looking at your pieces, okay? The colors will change from manufacturer to manufacturer sometimes, which is a pain in the butt.
Really is.
So you do, it doesn't matter, you can practice for 20 years in the field. But because the different manufacturers do that, you still have to read your pieces. Also, the flow rates that it tells you to set it at change as well. Mine actually will probably be different from what you have when we do our math because we have different manufacturers. I don't know why. I'm sorry. All right. But do me a favor and grab your 24% and your 50% piece. Are they the same color? Yes! Okay. It looks like we both have blue and orange. Thank goodness. This is a good day. Go ahead and look inside of your Venturi pieces. So if you look at your 24%, it's like a pinhole inside of there versus look at your 50%. It's a pretty wide open hole.
Yes.
Your 24% entrains more room air and less O2. Whereas your 50% Venturi piece is going to entrain more oxygen or use more oxygen and entrain less room air. Hence the difference in the size of the holes where the O2 comes in. Does that make sense? Okay. If you also flip these over, and look at the liter flow that these are run at. Sometimes you gotta like tilt the light on it a little because they're kind of hard to see. Your 24% Venturi mask, what does yours say?
3 liters per minute.
Mine says 2. I know. I know. I don't know.
3 liters.
No. Sorry. No. That's interesting. Okay. All right, so yours is a 3, mine is at 2 liters per minute versus your 50%, which what is yours at?
15.
15 liters, mine is 12. It's okay, I'm gonna go by what yours says. But it tells you exactly what to set it at. Okay, but hence why you will have to know the 6 FiO2s that come in all Venturi masks, but you will always have to pretty much look at your equipment to see what liter flow we run it at, because it's gonna vary from manufacturer to manufacturer, and sometimes the colors can vary as well. Okay, does that make sense? 24%, 28%, 31%, 35%, 40%, and 50%. That will never change when it comes to a traditional Venturi mask. Okay? It doesn't go above 50%. It doesn't matter how much you turn up the flow rate, it will not go above 50%. It will not change. So, like if the RN calls you to the bedside and they're on a 35% Venti mask, they're like, I turned up the flow rate. Is it gonna change your FiO2?
No.
Nope. It doesn't matter what you change your flow to, it will not, because it's a high flow system. That's okay, that's why we practice and look at the pieces together. Okay, so that's really important because you're gonna be like, thank you, but you know, and you don't wanna be like, what did you do? It doesn't change. No, we're just gonna be like, thanks a lot, and then you're just gonna get your pieces and up it. So they're on 35% and their SpO2 is low, they're tachycardic, right? They're using accessory muscle use. Is that 35% working? What do we have to do? Go up. What would you go up to? What's the next in line? 40%. So we would put a 40% on and do what? Assess. You reassess. You don't leave your patient until you are satisfied they are no longer in respiratory distress. If 40% is not cutting the bacon, what are we going to do? Go up to 50%. Okay, then what are we gonna do? Assess our patient. Make sense? Okay. So remember back when we had our patient on the nasal cannula? Remember that? They were on a 4 liter per minute nasal cannula and their respiratory rate went up to, was it 30 or 32? We'll just say 30. We'll say 30 breaths per minute. We decided as a group, do they still qualify for a low flow system? No. So we had to change to a high flow system. Who wants to be brave and tell me what the approximate FiO2 is for a 4 liter per minute nasal cannula? Remember, we started at 24.
28.
Oh, say that again?
So they're on a 4 liter per minute nasal cannula.
36%.
Yay, 36%. So they're on approximately 36% nasal cannula. And we've decided through assessment they have to go to a Venturi mask or a high flow system. What FiO2 would you choose? They're on about 36%. Is there a 36% Venturi piece?
No.
What's closest?
35.
You could do 35, or if you want to be a little bit more aggressive, I am always like a smidge more aggressive. Professor Forrester usually tends to err on the closer side of it because if someone is breathing 30 breaths per minute on a 4 liter per minute nasal cannula, do you think they're bringing in a ton of room air?
Oh, yeah. Yes.
Yep.
Yes. So their FiO2, even though we have learned it's approximately 36%, is probably lower. They're probably bringing in a ton of room air. So it wouldn't be bad to start at 35% Venturi mask because remember, oxygen is a drug. I don't know what you would do, Professor Quinn, but I would probably go to a 40% Venturi mask. What would you do?
I would put a normal breather on them.
What is that, a high flow?
No. That's what I would do. I would probably, I mean, if we're going high flow, I would go the highest possible.
You would go
on the
to the
bench
gusto? Okay.
Yeah.
So always gonna be some varying opinions, right?
Yep.
What do you wanna go to collectively so we can practice setting it up?
35.
What FiO2 on the Venturi math?
What would you like?
What's the lead?
Pick one.
Well, the liter flow depends on the piece. We gotta read it. I like 42 Ikea, so why don't we do that?
Okay.
Does that sound good? Okay. All right, very good. So you have your, oh, yours is clear, mine's blue. It's okay, this varies as well. So we have our mask. So everybody grab your mask, your aerosol face mask, and your 6-inch piece of corrugated tubing is gonna go onto the end of that, just like so. Yours may have already been together, it may not have. So it's gonna hook onto the mask just like this. How's everybody doing? Okay. Excellent. Very good. All right. Next up, get your 40% piece, and it looks like a little collar. Oops. You got it? Okay. So your 40% Venturi piece, and it's like a little plastic collar. The Venturi piece goes right inside of the collar, just like so. Can
It's a
everybody
snug
see it
fit.
okay? It's a pretty snug fit, yeah. Yeah, good, good. So snug it right in there. Everybody good? Then that goes on the end, and I usually grab it by the nipple adapter and just kind of wiggle it into the other end of your corrugated tubing. If your collar pops off, it's okay. Just pop it back on. Everyone good? Flip it around. You're actually going to connect it to the Venturi piece. No, you had that right. You had that right. There you go. Look it in there and then flip it around. Boop. There we go. Everyone good? Then we take our oxygen tubing. Thank you. And this goes onto the nipple adapter. Just like so. I encourage you to take pictures of things if you're not videoing, video recording, videoing, I don't know. Okay? Then we would hook it, and the reason, what do you think the purpose of this little collar is for? When you have a,
No, go ahead.
go.
To prevent
Okay.
ingestion of particles like dust.
Or, you know, if you ever see, I know when I have like a fever and I don't feel well, I'm like hot, cold, hot, cold. Well, also I'm like pre-menopausal, so that happens a lot too. But you have like covers and sheets. Sometimes you walk in, the sheets are over the patient's head. There's a lot happening. Blankets. This protects the Venturi system. So that if sheets or blankets or what, Chuck's pads, towels, hair, paper
Pillows.
towels, I don't know, anything. It protects the Venturi piece so it doesn't block the openings. Do you see the openings? Does that make sense? So this is very important. Then we hook it up to, mine's gonna be different. What does yours say? 15? Mine says 8. You just follow what the piece says.
What says 15? Show me.
Pink one. It said 40%.
Wow.
50%.
I know. Yep, welcome. Welcome to the
That's
madness.
wild.
So mine says 8, so I'm gonna set it at 8, but what would you say yours at?
15.
15, okay? Then we place it on our patient. Boop. Okay? What are we going to then assess? How do we know if it's working? I'm gonna turn this off so I can hear y'all. What are we gonna assess?
Respiratory rate.
Vital signs,
Respiratory rate.
pulse ox, respiratory
Respiratory
rate, their subjective response. How are you feeling? Is this helping? If they had cyanosis, do we want that to continue?
No.
They're using accessory muscles. Do we want that to continue?
No.
So we want to alleviate the work of breathing. the work of the heart and treat hypoxemia. And the only way to know if we're doing that is we have to assess. So if we put this on our patient and they are starting to calm, the distress is going away, they're improving, their vital signs are improving, their SpO2 is improving, their work of breathing is going away. Are we happy with this?
Yes.
I'm happy with it. Okay? If they needed more than 40%, what would you go up to with the Venturi mask?
15.
50%. And you would literally take it off, switch the piece real quick, turn the flow to what it's needed, and put it on your patient. Then what do we have to do again?
Assess patient.
It seems like a lot of assessment,
Yes.
right? Can you see why we were stressing patient assessment? But what if they need more than 50%? Can the Venturi mask go above 50%?
No.
Guess what though? Guess who can?
All purpose.
Okay.
So when I take it off, do I still, do I leave it on when I'm taking it off, or take it, turn it off before I change it?
The flow meter?
Yeah.
Oh, you're gonna be real quick, like lightning. I would leave it on. You gotta switch it real quick because this is you don't wanna interrupt their their oxygen therapy for too long because this is a patient in distress. So that's why we practice in here first, so that you get very proficient, very quick, so that when you go out there with a real patient, you're going to be very efficient and very quick. This can go up to 100%. Yeah?
I prefer that.
Cool, right?
Yep.
So if we're on a 50% Venturi mask and it's still not working, we would use the all-purpose Jet Neb, and we can go higher. We can go all the way up to 100%. Y'all had seen O2 Analyzer? Is this sounding familiar? Remember on your Bland aerosol checkoff? When it said verify with the O2 Analyzer? Or set your FiO2?
And we skipped that.
You know where those are?
Nope.
Somebody put their cup in the trash can. Boom. Where was that? In the baby bassinet. Because with babies.
Oh,
we
I have
always
not
to-
touched the baby bassinet at all. So that would explain why I did not know where it was.
Boop. So remember not trade color, but on the Bland aerosol checkoff, it literally said like analyze,
Oh, yeah.
oxygen, set the FiO2. We put non-applicable on this checkoff that just passed because you hadn't learned it. But now that you have, this is the O2 analyzer.
Oh.
And say the patient is wearing their Venturi mask and we need to verify, or the all-purpose Jet Neb, we need to verify. Okay, does that make sense?
Yes.
This device right here, the O2 analyzer, you have to calibrate it to room air, which is what?
21.
21%. So when we're calibrating it to the low, that's 21%. So we literally just hold it to the air. And if it's at 25%, we would use the dials to correct it. Just like we calibrate any type of equipment. Then when we read the high O2, we literally stick it right onto the flow meter. Because coming out of the flow meter is 100%. It's pure. And it should say 100%, and if it doesn't, then we have to use the dials. That's how we calibrate an O2 analyzer. So that's what it means in your checkoffs that you verified it. You would use the O2 analyzer literally right at the patient. You're analyzing and looking at this to see what the FiO2 is reading out as. Does that make sense now?
Yes.
Okay. You've already learned how to set an all-purpose Jet Neb, but I want you to practice it. You only have a week before checkoffs, okay? So you will have to be able to possibly set this up for your checkoff. You're gonna have to be able to set up all the systems we just talked about, and you're gonna be able to have to tell us if it's working, and if it's not, what do you do next? You're gonna have to tell us the goals of O2 therapy, why we use it, right? You're gonna have to tell us who qualifies for a low flow versus a high flow system. Does that make sense? And the last thing you'll have to do is calculate total flow, okay? Make sense? So I'm gonna, da-da-da. this on, because I have a feeling Pat's gonna need it. This is only for, you can only calculate total flow. Here's a couple pieces that I forgot, which always happens. You can only calculate total flow for a high flow system. So can we calculate total flow for a nasal cannula?
No.
Can we calculate it for a non-rebreather mask?
No.
Can we calculate total flow for a simple face mask?
No.
What about a partial non-rebreather mask?
No.
Okay, do you get what I'm saying? Okay. Sound good? What are the high flow systems that we can calculate total flow for?
All-purpose jet neb and venturi mask.
Excellent. So your all-purpose jet neb and your venturi mask. I can tell you clinically, you will start with, not that an all-purpose jet neb is wrong, but you're usually going to start with the venturi mask. And if you need higher than that, you're going to go to your all-purpose jet neb. And if you need higher than 50% FiO2, then you would go to your, does that make sense? All-purpose jet neb? Okay. Remember how we had said that a high flow system meets all the patient's needs and that the FiO2 will not change based on the patient's varying respiratory rate and tidal volume? Well, part of what all the patient's needs is their minute ventilation, their flow demand. Have you learned minute ventilation yet? It's okay, it's a very simple calculation, but you're gonna have to know this. Your minute ventilation, and you can feel free to take pictures of this or however, whatever works best for your system of studying. But remember, this is on page, page 302, okay? I used the exact one. The only thing I added was 100%, that's it, okay? Your minute ventilation is respiratory rate times tidal volume. We all have a minute ventilation. Normal is 5 to 10 liters per minute. So ideally, if a patient is doing well and not in distress, right? They're gonna have a normal minute ventilation between 5 and 10 liters per minute. But the patients that we're dealing with are not doing well. They're in the hospital typically for a reason. It could be pneumonia, it could be the flu, it could be COVID-19, it could be from transplant, it could be they were septic, it could be from burns, it could be from trauma, motor vehicle accidents. Do you know what I'm saying? Lots of different stuff that's gonna make us not feel well. Okay? So, we have to first figure out what the patient's minute ventilation is. Then we can calculate total flow to make sure we're meeting that demand. Make sense? Okay. So let's do an example of minute ventilation. So respiratory rate. Remember, this is a patient that requires a high flow system, so their respiratory rate is greater than what? 25 typically, right? So why don't we do a respiratory rate of 26 times, we'll do a tidal volume of, I'll do 250. But in liters, that's 0.250, okay? Make sense? So 250 mLs is 0.250 liters. Minute ventilation, what is the unit of measure that I have up there? Liters per minute. So we have to make sure we're doing the math in liters per minute. And liters. Does that make sense? So does anyone have, I have a phone, never mind.
0.5 liters per minute.
0.5?
6.5.
Oh, 6.5. Okay. Thank you. So this equals 6.5 liters per minute. Okay? So we know that when we deliver oxygen to our patient through the high flow system to meet all of their needs, we have to be giving them at least a flow of 6.5 liters per minute. Does that make sense?
For that, did you just use random numbers?
Yeah,
Oh, okay. I was trying to.
random. We're gonna do a couple examples, okay? All right. Sound good? So, Then we have to calculate total flow. Because I'm like, okay, well, now I know what the minute ventilation is, which we will give to you during the checkoff. We will give you the patient's minute ventilation that they currently have. Then you are gonna have to calculate total flow to see if that is meeting or exceeding their needs. Does that make sense? So let's do an example. What was our patient on, the 40% venti mask? Remember?
Yes.
Yep. So 40%, which is right here, is a 3-to-1 air to oxygen ratio. Air, oxygen. Are you noticing a trend with oxygen? It's always 1. See, 1, 1, 1, 1, 1, 1, 1, 1. What changes is your air, the fraction of air. Okay? So 3-to-1, so our example is a 0.40 or 40% venti mask. So what we do is we have to add the parts air to the parts oxygen and multiply that by the flow rate. So that would be, parts air is what? 3.
Plus 1.
It is gonna be 4 total, whoever. So 3 plus 1 times, what was the flow rate that you had to set on your Venturi 40% mask?
15.
15 liters per minute. So 3 plus 1 equals 4. And then 4 times 15 is 60. Thank you. 60 liters per minute. Is that greater than 6.5 liters per minute?
Yes.
Way exceeding. So are we meeting or exceeding this patient's needs
Exceeding.
with flow? We're way exceeding it, right? Make sense? Everyone good?
Yes.
Okay.
Is that 40? Is that supposed to this is V? Is that supposed to be V?
Venti mask.
Oh, venti
It is a
mask.
point.
Oh.
So see how we always,
Oh.
remember it's a fraction? So I have to write it as either a decimal point or I have to write it as a percentage. They're the same. Most of the time when you see the air to oxygen ratio table, it's gonna have it in a decimal point. So see how 40% is 0.40? And that is 3-to-1 air to oxygen ratio. And you're gonna have to memorize this. I'm sorry, but at least you have it in your textbook too, so you can memorize it anywhere, right? Because what we're gonna give you is the minute ventilation that the patient is doing. Then you have to calculate total flow for whatever device you have them on, whatever FiO2 you choose, calculate total flow and let us know if it's meeting or exceeding the needs. Does that make sense? That's what, I'm trying to just like make this as easy as possible for you on the checkoff. So when you have a patient on a high, it can't be a low flow. So if they're on a high flow system, you're gonna have to calculate total flow. Meaning you have to memorize this chart and whatever high flow system, I'm sorry y'all. It's ragweed time. Okay, we had our patient on a 40% venti mask, so that's why we use this as the example. So for example, during your checkup, you had your patient on a 40% venti mask. We would give you the patient's minute ventilation. You have to calculate the total flow of your system, and then we're gonna say, does that meet or exceed the patient's needs? And you have to say yes or no, and it has to make sense. Okay? Good? Let's do another example. So say the 40% wasn't good enough and we managed to work our way all the way up to 100% all-purpose jet neb. Sound good? Let me change a couple things here. Okay, I'm gonna tell you right now, you know how to do the math, that the patient's minute ventilation is gonna be, we're gonna say 30 liters per minute. I know it's pretty high, okay? But I want you to understand the point of this, okay, this exercise. All-purpose jet, no, where is it? Liter flow, what do we set this at?
10.
10 is your friend, right? They're on 100%. So can you all see 1.0 is 100%? What is it? 0 to 1. So they're on 10 liters per minute. So 0 plus 1 times 10 equals,
10.
what's 0 plus 1?
1.
What's 10 times 1?
10.
There we go. 10 liters per minute is the total flow, and their minute ventilation is 30 liters per minute. Are we meeting or exceeding this patient's needs?
Medium.
How high can we go for the flow rate though?
As high as we can.
We're on 10 liters per minute right now. How high can we go?
15.
We can go to 15. Y'all want to try that?
Yeah.
All right. So we increase the flow rate to 15 liters per minute. So what's 0 plus 1?
1.
1 times 15.
15.
15 liters per minute. Oh dear. Because we've kind of maxed out here, right?
Mm-hmm.
And are we meeting or exceeding the patient's needs? Their minute ventilation demand is 30 liters per minute, and we're only giving them 15 liters per minute. Is this going to work for our patient?
No.
No, it is not. Now, you don't know this equipment yet, but you may have heard about it during COVID. It's called a high flow nasal cannula. It is wonderful. You won't learn it until next semester, but we do have somewhere to go from here, but we just have to kind of stop at this point. But what I will tell you is your high flow nasal cannula, which is heated and humidified, okay, for airway clearance and mucociliary function, also goes up to 60 liters per minute in an adult. Would that help our patient who has a minute ventilation of 30 liters per minute?
Yes.
It certainly would. So we're not going to go over that yet. I just want you to know that, like, okay, this is where you have to critically think. This is not, the all-purpose shut-up is not working. So now we have to go to your high flow nasal cannula, which you will learn about next semester. Okay? Yay! Look at that, like 4 minutes to spare.
Nice, good job.
So if y'all want to like go, so that's what we're going to do right now. I encourage you to get up, walk around, maybe go get some water. Professor Nolan will be in at 10:30, okay, to talk about if you have any questions with Castle Branch. And then once Professor Nolan finishes, we're going to go over your oxygen scenarios, and you can work on that as a group because you've got to practice setting these things up